Bismillahirrahmanirrahim. I would be talking about systemic lupus erythematosus, and this lecture is mainly intended for medical students, but it can benefit residents and even senior if you would like to just quickly update himself about systemic lupus erythematosus. As we all know, it's a multi-system disease, and its etiology is of various etiological factors. Probably genetics plays a major role in systemic lupus erythematosus. Drugs like isoniazid, procainamide, hydralazine are very famous for causing systemic lupus erythematosus-like disease. Some environmental factors are also incriminated, hormonal factors and epidemiological factors, as you find it in certain places much more than others. In Saudi Arabia, it's 19 in each 100,000 of the population. It's important to mention that the clinical features might be quite variable, and single patient might not look like the other patient. So you need really for this disease to keep your scope widely enough to accommodate the various presentations of the disease. This disease affects females much more than males, and actually it's like 9-1. So each 9 females you might find one single male patient. So however, although it's a large percentages of the disease seen in females, however, males are not exempt, and you'd find once in a while, Usually starts at the childbearing age for the females, and this is the tragedy of the disease because it affects somebody while he's in peak of his productive life. What are the clinical features of the disease? As we have mentioned, it's a multi-system disease. So, from indolent to fulminant, it can vary, and usually increases in the postpartum period, characterized by malar flush on the face that's seen on the cheeks. And it's very important here to mention a very characteristic feature of the disease. If you look at the cheeks of the patient and the nasal bridge, they would be involved. But interesting enough, they would be perioral, sparing from the rash. So the rash affects the cheeks, the nasal bridge, but it spares the perioral area. That's to say, the nasolabial folds are not affected, and the area around the mouth, usually it's not affected. This is very characteristic, and it can differentiate it probably from other diseases like acne vulgaris, for instance, other forms of dermatological problems that affect the face. So if you find this perioral sparing, you should think about systemic lupus erythematosus. Multiple ulcers might show up in the mucous membranes, in the mouth, and renal involvement, unfortunately, occurs in a good proportion of the patients. Usually to the start is proteinuria, urinocellular casts. Seizures is very important in patients with neurological affection. Some hematological abnormalities might be found, like leukopenia, thrombocytopenia, and hemolytic anemias. So also fever is an important manifestation, although it's not seen in all patients. And as we have mentioned, every patient has got his own way of presentation. So that's why now the guidelines are going for 4 out of 11. I'm going to discuss this later on in one of the slides. And lymphadenopathy could also be present in some patients. This is the malar flush, which characteristically spares the nasolabial folds. And this is mucus ulcers and Raynaud's phenomena, which could be present in patients with systemic lupus erythematosus, but could also be present in patients with other connective tissue diseases and patients with mixed connective tissue diseases. This is Zika syndrome. Those are the clinical criteria and those are the immunological criteria, and you need 4 out of those criteria to diagnose patients with systemic lupus erythematosus. 1 of them should be clinical and 1 laboratory as the least requirement for the diagnosis. So I would go quickly over the clinical criteria: acute cutaneous lupus, chronic cutaneous lupus, oral and nasal ulcers, non-scarring alopecia, arthritis, serositis, and this is inflammation of the serosa, like pericarditis, pleurisy, peritonitis. Those are all important types of serositis. Renal affection is very important, neurological, hematological, leukopenia, thrombocytopenia of less than 100,000 per cubic millimeters, and immunological criteria such as positive antinuclear factor antibodies, anti-double-stranded DNA antibodies, anti-smooth muscle antibodies, anti-phospholipid antibodies, low complements, particularly C3 and C4, and direct Coombs test. And interesting enough, it usually doesn't count in the presence of hemolytic anemia. What other investigations that we should consider for our patients in whom we are suspecting systemic lupus erythematosus? We should screen the patient fully for complete blood count, that's with a differential count as well, looking for anemia, leukopenia, thrombocytopenia, serum creatinine to look for any renal affection. Early on it might be quite normal in spite of the presence of proteinuria, but we have to keep an eye all the time. Urine analysis with microscopy, looking for proteinuria, hematuria, and the CAS. And ESR, C-reactive proteins levels. Usually, interesting enough, C-reactive protein level in patients with systemic lupus erythematosus is usually normal, except if the patient is having a secondary bacterial infection or any other surgical problem, like acute abdomen, for instance, it would be high, or if the patient is having infection, as I have just mentioned. Autoantibodies tests, nuclear factor antibody, anti-double-stranded DNA antibodies, complements, particularly C3 and C4. Liver function test might be also touched because it can affect also the liver. Creatinine kinase assay, and particularly in patients with mixed connective tissue disease, this might be profoundly increased. Spot protein and creatinine ratio, the kidney affection, and more investigations such as joint radiography. It's important here at this junction to mention that patients with systemic lupus erythematosus, usually the type of joint affection is a non-erosive arthritis. Interesting enough, even if you find deformities, then it's usually the correctable type of deformity. Chest radiography, chest CT scan, echocardiography looking at the heart, the valves, the Liebman-Sachs endocarditis, brain magnetic resonance imaging, and magnetic resonance arteriography are all beneficial. Cardiac MRI. Sometimes you might need to go for some procedures like arthrocentesis, lumbar puncture, renal biopsy, and then treatment By treatment, we would come to the last slide of our topic. And usually you would use antimalarial like hydroxychloroquine, and as we all know recently it has been used for COVID-19, and there is lots of debate about hydroxychloroquine. However, there is a paper in the Lancet that has shown that the mortality rate is increased with hydroxychloroquine. Corticosteroids, hydroxychloroquine is very beneficial for patients who are presenting with arthritis and arthralgia. And of course, it's also an antipyretic. It helps also in patients with fever, but we are not going to use it just because the patient is having fever. It's much more used in patients with arthralgia and arthritis. Corticosteroids, it's a potent anti-inflammatory like methylprednisolone, prednisolone, and usually we would go for short-term use. This is the recommendation, although sometimes you might go on for longer periods, but we have to search and anticipate and look for any complications of corticosteroid therapy, particularly hyperglycemia, hypertension, electrolyte disturbances. And in long-term treatment with corticosteroids, we have to keep an eye on the bones because it can lead to osteoporosis. And of course, there is lots of side effects of corticosteroids. I advise you to go ahead and review them today after listening to my lecture. There is a non-biological treatment like cyclophosphamide, methotrexate, azathioprine, mycophenolate, and cyclosporine. Also, non-steroid anti-inflammatory medications might be of help, and I would really recommend ibuprofen because it doesn't affect the kidneys, and maybe it has got a lighter effect on the stomach as well. Biological treatment, disease modifying, this is DMARDs, or disease modifying anti-rheumatic drugs like rituximab, IV immunoglobulins are all used, but usually just by the experts. This we come up to the end of our lecture, and thank you very much. I would like you to subscribe to my YouTube channel. Thank you so much.